Hi, so this final video in our series on nerves of the upper limb will look at the brachial plexus. So the first case is a 17-year-old male patient who presents to the emergency department with a dirty complex laceration to the left upper limb. A decision is made to utilize a brachial plexus nerve block to provide anesthesia. We're going to use this case to consider the anatomy of the brachial plexus and its clinical correlates. But just before we do that, let's just think about conceptually, what is the brachial plexus? Well, if we think about the upper and lower limbs as specialized musculoskeletal appendages of the axial skeleton, then the brachial and lumbosacral plexuses are plexuses and combinations of nerve roots to provide innervation to these structures. The brachial plexus is divided into roots, trunks, divisions, and cords. The roots arise from the nerve roots of C5 to T1 spinal levels. The trunks are the combinations of these roots. So the upper trunk is made up of the combination of C5, 6, the middle trunk C7, and the lower trunk C8, T1. These trunks then divide into anterior and posterior divisions. The posterior divisions carry innervation to the extensor aspect of the upper limb, whereas the anterior divisions carry innervation to the flexor compartments of the upper limb. And finally, the cords are formed by a recombination of the trunks. So there's a medial, lateral, and posterior cord. And from these cords arise the terminal branches of the brachial plexus. The medial cord ends in the ulnar nerve, whereas the lateral cord forms the musculocutaneous nerve, and branches of both the medial and lateral cord form the median nerve. The posterior cord, the terminal branches are the radial and axillary nerves. It's important to understand the anatomical relations of the brachial plexus, both to help us understand injuries that might occur and also to conceptualize the anatomy behind brachial plexus nerve blocks. So the roots emerge from between scalenus anterior and scalenus medius in the neck laterally. The plexus then runs down and laterally across the anterior triangle of the neck, deep to the deep fascia in relation to the subclavian artery initially and then the axillary artery. Higher up, the plexus is superior and slightly posterior to the subclavian artery, and then lower down, the cords actually encircle the axillary artery and lie within the vascular fascia, which contains the axillary artery and its accompanying veins. So this is the level of the roots, just behind scalenus anterior. Then we have the divisions and trunks and the divisions, and then the cords. And here we can see the close relationship between the cords and the axillary artery. Here are three approaches to the brachial plexus for the purposes of regional anesthesia. The first in the upper left corner is the interscalene approach, high up in the neck, aimed at blocking the plexus at the roots. The second is the subclavian approach, So the needle goes in below the clavicle but above the first rib. And here we're aiming at the trunks and the proximal aspect of the cords. And finally, the axillary approach, in which we are trying to get into the vascular fascia and inject around the axillary artery, where, as we said before, the cords are closely related to the axillary artery. This table shows 4 common approaches to the brachial plexus for the purposes of regional anesthesia, the structures blocked, and the level of anesthesia. And as you can see, the more proximal blocks produce a more proximal level of anesthesia, while the more distal blocks produce a more distal level of anesthesia. For each approach, there are some specific complications. It's actually important that you understand these nerve blocks to some extent, particularly with regard to complications. So what I would advise is just stop the video here, pause the video, and have a proper look at this table. So let's look at some cases. The first is a 34-year-old motorcyclist brought in after falling off his bike at high speed. He has a bruise over the distal end of the left clavicle and complains of weakness in the upper limb. Pause the video, see if you can work out what's going on here. So this is an injury to the upper trunk of the brachial plexus due to forceful depression of the shoulder and lateral extension of the neck away from the side of injury, and that causes stretching of C5-6. This can be produced, as in the case before, falling onto the shoulder, or is sometimes seen as an obstetric complication with shoulder dystocia, where the shoulder is forcefully depressed and the neck extended when we are trying to deliver a baby this a little large for the birth canal. The axillary, suprascapular, musculocutaneous, and radial nerves are affected, and on physical examination, the limb is in the typical waiter's tip position with the shoulder adducted, the upper limb internally rotated, the elbow extended, the forearm prone, and there's loss of wrist extension. These are usually due to neuropraxia, and patients have a good recovery. These pictures on the left shows the mechanism of injury in a motorcyclist falling off his bike, whereas in the right it shows a typical position in a baby who suffered shoulder dystocia. The second case is a 34-year-old construction worker brought to the emergency department after falling from a height. On the way down, he grabbed the scaffolding to prevent his fall and stretched his right arm upwards and outwards, so a hyperabduction injury. He now complains of weakness in his right upper limb. Again, pause the video and see if you can work this one out. This is a lower trunk injury, and the mechanism is usually severe hyperabduction and traction at the shoulder. It can be seen in obstetric cases, so in neonates, arm presentations, or difficult breech deliveries, and in adults with falls and trying to break the fall with the arm, as described in the case. C8 and T1 are affected, as well as the sympathetic nerve trunk, so the patient tends to have weakness of the intrinsic muscles of the hand and Horner's syndrome. On examination, the patient has a claw hand involving all the intrinsic muscles and Horner's syndrome. Unfortunately, these injuries often are accompanied by more severe nerve damage, and prognosis is poor. So if you have any questions, you can ask them in class. In this short lecture, we covered brachial plexus injuries, brachial plexus regional anesthesia, and the anatomy of the brachial plexus.